All right. Just want to say thank you to Neil. Where is he? Neil. Um, Thank you for setting this up. I couldn't have done it without you. And I want to thank Dr. Rhodes and Pamela Barney for letting me be here tonight. They didn't ask me, I begged to come. So this is all me. And thank you, Dr. Patterson, for giving that introduction. And I wish you well once your career ends. Where'd you go? Down there. Okay. All right. The evolution of robotic surgery and the Da Vinci 5. So hopefully you've been able to play on this incredible piece of machinery. And if you're ever interested in general surgery, that's not the future, that's the present. Okay. So if you go into general surgery or urology or gynecology, you're going to have this at your disposal. And this has really changed how we do surgery. Okay. So I purposely didn't put the Da Vinci up there because we're going to eventually get to it, but I wanted to just include this robot here because you never know. There will be robots doing surgery and you will just be watching them, but it's not going to be in my lifetime. Okay, I have to give a disclosure. This talk is pretty much sponsored by Intuitive. They provided the meal for you. Thank you for Lance. If you've not been able to meet Lance, he is an asset in the community when it comes to robotic surgery, and he provided the robot. So, of course, I'm indebted to Intuitive, and I have to give a disclosure, and I do work for them. So, and the only reason I work for them is because they're the best, but they're the only. There's no FDA approved platform in the United States other than this one. So, there's your disclosure. Okay, who is this guy? All right, that's an older picture of me, and I purposely gave that to Neil because this guy doesn't exist anymore. Okay, so, a well-established, confident laparoscopic surgeon pre-2017. Okay. In 2017, I thought I was the top dog in Riverton. I was doing everything laparoscopically. I was very confident in my abilities. And then I went to the American College of Surgeons in 2017. I hadn't been there in a couple of years because I was so busy, couldn't take time off from work. And every single lecture that was given in general surgery included something about robotic surgery. And I thought, I have missed the boat. I am behind the power curve. So at that time, I was like, I'm fine with straight sticks. I don't need a robot. I don't even know what this is about. But then I went to the American College of Surgeons and I said, I have missed the boat. Okay. Then I went from a quadruped to a biped and found a robotic surgical platform. I got off all fours, learned how to walk, and got into robotic surgery. Okay, so up here, I'm a quadruped, all right, just kind of lumbering around doing laparoscopic surgery. And then this progression is very similar to the talk. This is the ASOP, this is the Zeus, this is the S, this is the SI, this is the XI, and then this is the 5. Now, you notice the posture is not good. Um, that is not what I do in surgery. I'll show you a picture here shortly. But here I am doing surgery with now computers, okay? So this is a picture in 2024. This is me right here. I'm on the continent of Africa in Angola. I'm in the army, and we did an exercise with the Angolan surgeons. And if you'll notice, I'm doing a laparoscopic cholecystectomy, which I never do in the United States anymore. This technology is essentially 1990 technology, and it's the year 2024. I am doing a lap chole. Look at my eyes. They're looking over here to a screen. Here's my hands going down. Huge disconnect in eye-hand coordination, okay? And I'm standing up. Am I standing straight? No, I'm leaning over. That's the most uncomfortable position if you do that all day long, okay? And look, think of the eye strain. The monitor's way over here. I can't even, I mean, I can barely even see the monitor, okay? This was 2024 in Africa, but that's the way it goes. Now here, this is me. You notice the posture. Okay, I've got my hey dudes down there. I'm just relaxed. I'm chilling. My posture's straight. My eyes there. Now I've learned how to keep my head in the console without straining my neck. A lot of surgeons incorrectly put actually touch the console with their forehead, and that's incorrect. You just put your head in there. Now the beauty is that thing conforms to your head. That's the beauty of this new system. Okay, this is me with the joysticks. You put your first and your third finger in these rings. Your second finger works this toggle, and then you have 7 pedals down here that you use. So that's your that's your hand and your foot working simultaneously. And then this is the technician at the bed working with the tower. Okay. And they're changing all these instruments out for me. And this one, I think we are doing a gallbladder right there. Okay. Okay, so this is the first system that was developed in 1993. A gentleman named Yulun Wang created the company Computer Motion, and he basically just made the system. The name is an acronym of the system. I don't know why he called it that. ASOP. It sounds horrible, but that's what it is: an automated endoscopic system for optimal positioning. But this guy was a genius. He's thought, let's put robots into surgery. So they had their first prototype called the 1000. It had one arm, endoscope, and it was manual. Okay, well, it's a start, but you know, it's like an Atari system. In 1996, now you had voice control with an arm. Now, I started my residency in 1996, and I remember we were in the operating room and we were talking about this, and we thought, "Oh, that's so cool! You could tell the thing where to go," because we didn't have it. I was in the military. We didn't have that kind of stuff. Okay, and then in 1998, now they had the 3000 motorized joint, increased freedom, so they're getting better. And then they had the Hermes Ready, so integrated with the operating room table and room lighting. Okay, so now they got really sophisticated. But guess what? You can buy these. You can buy them on eBay. Okay, I don't know what you're going to do with it. Put it in a museum or maybe use it in your garage. I don't know, but you can buy these if you want. I'm sure they're not that expensive. Okay, but this was the first. And I specifically remember right here in 1996 going, wow, that sounds pretty cool. All right. So then the next system that Computer Motion came out with was the Zeus. Now they're getting a little more sophisticated. Now we have three columns on the bed, so three arms. Okay, so this is really cool. You have 2001 FDA clearance, so Computer Motion came out with this. And then you have three arms attached to the bed, and the surgeon at a console controlling the arms. So what I mean by the console is this thing right here where you sit down. So that's what we're talking about there. Okay, now this is Operation Lindbergh. Okay, September 7th, 2001. What happened 4 days later? 9/11. Okay, so guess who was guess who was funding most of the robotic surgery in the United States at that time? Was the United States Army. Okay, they were working through the Stanford Research Institute, and they were developing robotic technology because they wanted to put a robot on the front lines so that soldiers can be operated on the front lines. The Army was very serious about this. Okay, so in I keep hitting the wrong button. In 2001, you did the first transatlantic robotic cholecystectomy. The console was in New York, and the robotic arms were in Strasbourg, France. Okay. So France Telecom was able to figure out the broadband and all the electronics needed so that there's minimal delay from when the surgeon in New York moves their hand to what happens in France. Okay, so you can't even recognize that there's a delay. All right. Now, I'm going to read you a text from a friend of mine who is actually doing research with the United States Army about robotic surgery and worked with these surgeons in France. So I'm giving you some information tonight about Operation Lindbergh, and why it's called Lindbergh is because that was the first person to fly across the Atlantic Ocean. So they called it that. So this is firsthand experience. He goes, well, I know that originally Dr. Jacques Marceau was going to perform the operation for one of the New York hospitals, but the legal team couldn't handle the fact that he wasn't licensed U.S. physician. So at the last minute, he moved to a hotel. Now, you're not going to read that in an article. Okay, you're not going to get that in a newspaper. You're getting it here tonight. This is very unique information. To this day, people debate whether or not Jacques was illegally practicing medicine without a license in the United States. In fairness, in Strasbourg, Dr. Joel Leroy was patient side and available as a contingency. So they had a surgeon in France, okay? And now he says something very personal. He goes, Leroy is technically one of the most gifted surgeons I've ever seen. So in a bit of irony, the backup might have been a better option than the primary, okay? Um, so then on the technical side, the communications line they used was submarine, which means that they're using transatlantic cables underneath the ocean. Okay. So the latency was actually quite low. At the time, the challenge for the military was trying to figure out how to deal with the latency involved with bouncing control signals off the existing satellite network, which was so far away from Earth that it introduced a ton of latency, even though the signal was traveling at the speed of light. This actually might not be a big deal now that Elon Musk, has created such an extensive network of low Earth orbit telecommunication satellites that are only a few hundred miles off the surface of the Earth. But here's the catch. This happened September 7th, 2001. 9/11 happened 2001. I never heard of robotic surgery again in the Army because we had more things to worry about than putting a robot on the front lines. So essentially just died. Then he said the solution group came up with to try and address battlefield telerobotic surgery was to propose using an AWACS. If you don't know what an AWACS system is, it's a plane with a big satellite on it, in a holding pattern at 40,000 feet to bounce the signal off of. However, in the end, we couldn't find any combatant commanders that would be ever willing to give up any of the bandwidth that they use for their battlefield communications, cruise missile guidance, etc., to help a wounded soldier. So therefore, 9/11 destroyed robotic surgery in the United States Army for research. Okay. All right, Intuitive Surgical, at the same time that computer motion was happening, they were creating their own prototype called Lenny after Leonardo, 3 separate robotic arms clamped to the table, just like the Zeus. In 1997, they had their second prototype called Mona. I'm assuming that's named after Mona Lisa because of Leonardo da Vinci. And they formed the first robotic cholecystectomy in humans in Belgium because, of course, it's not FDA approved at this time in the United States. Okay. Then they got their first FDA approval in the year 2000. And then Computer Motion and Intuitive Surgical merged in 2003 because they had a bunch of lawsuits going after each other. And then they just realized, you know what, it's better if we join forces and use shared technology. And once they did that, Zeus went away, and then Intuitive's models started to hit the market. So the first one, called the Standard, it's a good word, Standard. But if you look at it, it looks like something right out of a 1960s sci-fi movie. I mean, does that look like that? Not even close. Okay, but you got to start somewhere. And so this was FDA approved in 2000. It had 3 arms. All right. In 2002, whoa, they got 4 arms, but it's still the same platform. And then this is the beauty, though, is they introduced wrist action, 7 degrees of freedom and 2 degrees of axial rotation. So instead of using a straight stick like this in laparoscopy, now you have this internally instead of that. So that's the beauty of robotics, is you get the use of your hands again. And if you've used the platform, you know what I'm talking about. Okay. So you have 3 components. You have the surgeon console, which is here where you sit. So you have the joysticks, the pedals, the binocular stereoscopic vision system, the patient trolley, which holds the robotics arms, and then the imaging system, which is like the column over here, which has the insufflator and the camera. Okay, so this is their first one. It's probably in a museum somewhere. The second generation was the S model. Now it looks a little more sophisticated. Now we're getting somewhere. Okay, so this came out in 2006. You had interactive touchscreen display. So if you notice on the console here, you can touch the screen. So before 2006, you couldn't do that. So the surgeon can control a lot of what's going on with the robot from the console, and that's the beauty of it. It increased the amplitude of arm and movements to now perform surgery in several quadrants of the abdomen. And then they came out with the SI. This is where I cut my teeth. That's a term for where I got my experience. Okay. So you'll notice, though, you see this right here, that's the camera. And we're going to compare this camera to what the new cameras are. But this thing is a very heavy, cumbersome camera. It's a 12 mm port. Okay. So this one came out in 2009. And we had some really cool advances. Now you can have 2 consoles next to each other. So now you can teach people. So you can have an attending surgeon, you can have a resident surgeon, and now you can sit down. It's like driver's ed in a car, right? They can take over anytime they want. And it's really cool because you can draw on the screen and you can take over the surgery if they're having a hard time. Firefly, that's real-time fluorescence. So this is going from a white light spectrum to a near infrared light spectrum, and it's the flick of a finger, and you can change the light spectrum. So that was now introduced, and we use fluorescent surgery all the time in robotic surgery. High definition vision system. Okay, now you get into the XI. So the beauty of the XI is you have better arms, and this is the camera. So you see this compared to that. So it's a huge difference in the camera, and it came out in 2014. Now this year is very important, and the next slide I'm going to show you has a time frame, and 2014 is key. New patient cart, improved docking, and access to any quadrant. So now a surgeon can work in a different quadrant without having to actually get up from the bed and undock the robot. Okay. Minimize external collisions, increase internal range of motion just because of the way they designed the tower now. And you have now an 8mm camera. It's longer, does not have to be removed. That's the beauty of this right here. It's just a completely better system. Okay. And then you had integrated table motion while the surgery is in progress. Now, this is really nice because you do not have to do anything with the robot or the patient or the bed. It actually can, the anesthesiologist has this device and they can move the bed for you and you don't even have to get out of your chair. Okay. So that's another huge advantage of this system. All right. And then you had a bipolar vessel sealer. So if people haven't done surgery yet, that's where you have a device that's a bipolar. It clamps a vessel, it cauterizes it, and then it cuts it. So it seals it. Okay. And it can cut up to 7mm vessels, which is pretty big. And you have to have confidence in it. The first time you use it, you're very skeptical. But then after you use it a couple of times, you're like, oh, thing really does work. Okay. So now this is the graph that has changed my world. Okay. So you see right here, 2014. So it's just kind of not much growth. 2014 is when the XI came out. The general surgeons jumped on right here because now we have a platform that can be used in general surgery, not just working in the pelvis doing a hysterectomy or a prostatectomy. Now we can work up in the right upper quadrant. Now we can work in the left upper quadrant. Now we can work over here. We can work over there. So that was in 2014. That's when everything started to take off. In 2018 is when I jumped in. Now you have this huge increase in robotic numbers going across the United States and the world. Up here is laparoscopic surgery. So what they're saying is somewhere probably around in 2024, 2025, robotic surgery is going to pass laparoscopic surgery for minimally invasive surgery. And you'll notice the open surgery is going down also. And that's what happened in my practice. I was able to do surgeries now with the robot that I couldn't do laparoscopically. So then I cut down on the amount of open surgery I was doing. And there's no such thing as laparoscopic surgery in my practice anymore. So this line is now up here and this line is now down to 0. Okay. And I have reasons for that because I am a better surgeon with the robot and I've incorporated it into every single procedure that I do. So if you rotate through my program at Riverton as a third-year medical student, you won't see a laparoscope. Okay. You won't. All right. There's some numbers over here that don't really mean anything. Okay. Da Vinci 5. Okay. This is now the new system. So there's huge advantages to this and that came out in 2024. You have force feedback. Now, why is this so important? Because in the other systems, you can't feel what you're doing. All you can do is grab the tissue, and through experience, you can say, oh, I'm pulling on the tissue too hard because it's doing this. And you can run into problems with that. And I have run into problems with that. I have had problems with tearing bowel after I've done this beautiful operation. I'm just kind of cleaning things up. And next thing you know, I'm like, oh, I just tore it and I had to fix it. Patient didn't have any problems, but that was an issue, was force feedback. Now you have force feedback. Okay. They've gone to the next level. All right. Optimized vision. Okay. So when you sit down here, I can actually wear my glasses when I'm sitting at that console. In the XI version, I can't wear my glasses. I have to take my glasses off. I don't know the optics of that. I'm not an optometrist, but it's incredible how I don't have to take my glasses off anymore. Okay. Greater comfort and ergonomics. That's the beauty of this thing right here. This conforms to you instead of you conforming to it. It's better for you. More surgeon autonomy and control. So at this system right here, you can control this whole tower and you don't have to talk to anybody anymore. Because right when I'm doing a case now, I have to tell the nurse, oh, go hit this button. Make sure this is plugged in. Can you turn this down? Can you turn that up? And they have to leave their desk and go over there and I have to wait. Now it's on a touchpad and everything is coordinated. And so therefore, you have more streamlined workflow. The more efficient you are, the quicker the surgery. Okay. And then these are compatible with X and XI instruments. So you can still use them on this system if you have them. Okay. Improved data analytics. I'm not going to go in detail about that, but Intuitive is always gathering data. I have an app that I can look at my cases and look at my times and my instruments and all the different things. And you can come out with some pretty cool data, but it's very complicated. I'm not going to get into it. Okay. Improved energy generator and integrated insufflator. So that's all in this. And what this means is an integrated insufflator. Now they provide the insufflator, whereas before you had to use a different vendor. So you had another piece of equipment in the room. Now it's here. And the improved energy generator is also there. I won't go into details about that, just trust me. Okay, so this is a promotional video put out by DaVinci, and they gave me music. Well, this is a really good video, so I want you to see it. All right. We'll edit this in my talk. All right, here we go. It takes 3 minutes. I'll stop talking. Break.
Intuitive DaVinci 5 is our most advanced and integrated system ever. It's going to transform surgery for surgeons, care teams, and patients.
Well, I've never seen anything like this before. Force feedback is a first of its kind technology. In preclinical trials, we're seeing up to 43% less force on tissue. That translates to gentler surgery for patients.
Before we relied on visual cues primarily, but now with feedback, it does give you that extra sort of sense.
It's not something I've seen with any other system. It's something we experience in open and laparoscopic surgery, but not robotic surgery.
We're going to be able to control so many more things from the surgeon console now, which I think is really important.
It's really an immersive experience that gives you a next level of control that you didn't have previously.
The ergonomics, the ability for me to move the headset where my head goes in and move it exactly where I want it to be in a variety of different positions. I think that really is going to help elongate my career and make surgery more comfortable.
We are seeing DaVinci 5's capabilities result in faster surgery, which translates to our customers' ability to do more surgeries in a day.
I think having the integrated new components will make the process of starting the case a lot more efficient.
The insufflator being in the vision tower is just a huge thing. We don't have multiple vendors within a tower. We literally can offer everything that we need for the patient under one umbrella.
I think it will make rooms more organized, so helps with the staffing problem that we have, and also helps to reduce the cost.
DaVinci 5 will help surgeons unlock new answers to surgical techniques and patient outcomes with unique and granular data. DaVinci 5 connects more data than any other platform that I'm aware of and allows physicians and their administrators to link them to patient outcomes.
This opens up an opportunity for years of innovation and years of things that are going to come next.
I can't wait for surgeons to get their hands on this.
Now we have a platform, an approach to do minimally invasive surgery that is beyond anything that we could have seen in those incremental improvements. And that is what's giving us the magnification, the stability, dexterity, ergonomics, precision, all of which are key for us to be able to provide the highest quality minimally invasive surgery that we can to our patients.
We don't want to be behind in medicine. We need to be ahead. And that's what's really exciting about this next generation.
Okay, that last individual, Jessica Hunt, is a superstar that we have in Salt Lake Valley. She's a gynecology oncologist, and she's got a lot of experience using the robot. So that's why she's on there. Okay, so as medical students and faculty, you know that doing literature research is our life as doctors, and understanding the literature is very important. Okay, so the robotic cholecystectomy controversy is, I'm going to highlight this, and I'm going to tell you what the controversy is and how the experience at Riverton Hospital where we debunked that controversy. Okay, so in 2023, an article came out that says comparative safety of robotic assisted versus laparoscopic cholecystectomy. All right, so when you read that, well, that's a very fascinating article. So you wonder what they say. Okay, well, so they were Medicare patients between the years 2010 and 2019. So a very specific population. So it doesn't, can you really apply that to every patient that you see in your office? Well, not all my patients are Medicare. Okay. So that's the first thing I didn't like about this article. But the thing here is that this is under old technology, the SI, and then they probably started using the XI. So they're using two different platforms and one is superior to the other. So there's some variables in there that can be confounding. Okay, now what they find out? The rate of bile duct injury was 0.2% in the laparoscopic arm, and it was 0.4% in the robotic arm. Well, yeah, that's twice as many. But I'll get to it later. So there is a concern. The rate of post-op biliary interventions, like putting a stent in, was a little higher in the robotic. Now, this one I didn't really understand too well because here you have 0.2% bile duct injuries, and then you have 0.2% going on to get operative repair. But this number is a little higher down here for robotic, but they're not going to tell you the specifics about why they're doing this. But this is surgery to fix those injuries. Okay. Now here's the thing: those are trends. They are not statistically significant. And it says overall 30-day complication rates, no significant difference. So they're raising an alarm without actually statistical significance. They're saying there's a trend, they think it's alarming, and then they say, well, we have a safe system. Why would we want to do something different? Okay, that's more dangerous, but not statistically significant dangerous, just trending. So just you have to take literature for what it is. It's a trend, but it's with people probably dabbling, it's with older technology. So what did we do? At Riverton, we decided to prove that we're safe. So Intuitive, with it's called QTI, Quantify the Impact, they looked at some data that we went ahead and generated, okay? So what we did is once we got our robot in April 2022, for the first 100 gallbladders, we were going to incorporate something called the critical view of safety. And we were going to mandate that we do certain things in the operating room and after the operating room to prove that we are safe doing robotic cholecystectomies. And then when we had that data, we compared it to laparoscopic cholecystectomies that we're doing at the same time. So it wasn't intentionally to look at them both at the same time. What we did is we were like, well, why don't we just look at them at the same time after the fact? And I will go into the critical view of safety in the next slide. But we proved that we were cheaper laparoscopically. I mean, we were cheaper robotically than laparoscopically because we became more efficient. All right. So we proved we were cheaper using robots versus laparoscopic. Superior outcomes. We had no conversions or bile duct injuries. Conversion is conversion to an open surgery. Duration overall, when you compared inpatient, outpatient overall numbers, the robotic platform was quicker. Okay. You got them out of the operating room sooner. All right. So this is the critical view of safety. So if you come on my service, you better know this by the time you get there, and you will definitely know it when you finish. The critical view of safety is a technique of identifying structures developed by Strasberg in 1995. Sages asked him to come up with a system of identifying structures before you cut the cystic duct in a laparoscopic cholecystectomy because of the risk of bile duct injuries. So he came up with this idea of, well, before you cut something, you have to identify everything. It's not a dissection technique. It's an identification technique. And the goal was to reduce bile duct injuries, and they were successful in being able to do that. It has three components. You have two distinct structures. You have to identify the artery and the duct. You have to have them clearly identified. Then you have to have all fiber fatty tissue removed from the triangle. So this is the triangle you're creating. So all the fat in here has to be completely removed, and then you have to have exposure of the cystic plate. And that's the cystic plate here. So you're peeling the gallbladder off the liver bed. So if you have all three components, then you can actually say, I have obtained the critical view of safety, and then I can cut that cystic duct, and you're going to probably not cause any harm to the patient. Okay. So this is a picture using the robot of this is the triangle right here. Okay, it's not a true triangle, but that's the triangle right here. Here's the cystic duct. I've already cut the cystic artery just to make more room in here. This is the cystic plate, and all the fiber fatty tissue has been removed. Okay, so that is what the critical view of safety looks like. So it's very difficult to damage the bile ducts over here if you have that image. It's almost impossible, but I guess someone could do it. I guess if they were determined to do it, they could probably do it. And this over here is using Firefly. So this is fluorescent surgery. So this is the common hepatic duct. That's the common hepatic duct. You can't tell what that structure is under the fat, but you know it's the common hepatic duct when you're using fluorescent surgery. Here's the confluence of the cystic duct, the common bile duct, common hepatic duct. This is the fiber fatty triangle completely dissected out. This is the liver bed, and that's the gallbladder. So that's what it looks like. That's what a critical view of safety looks like. So what we did is we had 100 cases in each one. So we had two bile duct injuries in the laparoscopic time frame. One was a major injury, the other one was minor, but it's still an injury. We had none in the robotic. We had no conversions to an open procedure. They had one. Reoperations was one, but it wasn't for a bile leak. It was just for an infection. And there was two reoperations in the laparoscopic. What's interesting, the overall operative time, when you're looking at all the cases, was less in the robotic 100 cases versus laparoscopic overall. But the laparoscopic was shorter in the outpatient and longer in the inpatient. Okay. But you'll notice that we were the same if we were doing inpatient or outpatient. So if we had cholecystitis, it took as long as it did the other way. So we think it was better because now the most difficult cases were taking the same amount of time as the easy cases. The problem was that we had 55 over here and 74 inpatients over here, because at this time we weren't doing a lot of inpatient robotic surgery and we were still doing inpatient laparoscopic surgery. So the numbers are not, 50-50, 50-50, okay? Now the good thing is that we were able to get 97% critical view of safety out of those 100. And the best article I could find was 95% in any literature of obtaining critical view safety. And most of them were anywhere from 20 to 50% for surgeons. So it's not a very good number that people are actually producing. But we did 97. And then the 3 that we couldn't get the critical view safety, we switched to a bailout procedure called a top down, and we were able to safely get the gallbladder out without any bile duct injuries or anything like that. So our numbers are fantastic. Okay. So now this is a video of how, when you're dissecting out the critical view of safety, there shouldn't be anything in this triangle. But what have we here? All right. This is fascinating. And you'll also see the use of fluoroscopy. Okay. So that's okay. So now we're going to Firefly. And what you're seeing is this thing right here. So the surgeon is confused. He's like, I'm not supposed to see this. So you have a bifurcation down here, and you also have a bifurcation up here. You're only supposed to have one bifurcation when you're doing this surgery. So for some reason, now there's something up here. And so now there's a hook underneath this branch that's not supposed to be there. And it's going back towards the liver. So if you weren't paying attention, you would have probably cut that branch and then had a massive bile leak, which then would have caused damage to a segment of the liver. Okay, so this is what you call a right posterior sectoral branch. All right, it's a very uncommon variant of normal biliary anatomy. All right, you're not supposed to have that. But because of the ICG and the fluorescence that we use, we're able to identify it. So basically, the cystic duct is coming off the common bile duct here and going up to the gallbladder. But then there's this other branch going up to the liver. And you'll notice this branch right here is not attached to the main biliary system. So if you were to cut this branch right there, there's no way you can fix it because you can't access it through here. Because normally if there was an injury here, you put a stent up, cover that area with a stent, you're good. Okay, you can fix it that way. But this one, there's no way you can fix it. It's a done deal. And a lot of times this will leak. And if you go in there and you clamp that off, then that portion of the liver will die and you have to have a liver resection. So it is catastrophic if you carelessly cut that. So then what you do is you identify it and you cut it right there and you're good to go. So with the use of the robot, we were able to identify that very quickly using that type of technology. Okay. Now also narcotic usage. So that's a huge thing that is a problem in surgical patients. You don't want them to get addicted. So what can you do to minimize their narcotic usage? So I looked at 32 patients. Oh, let me go back. I looked at 32 patients that I did robotic cholecystectomy on and laparoscopic. Look at these numbers. 59 out of the 32 narcotics were used and 143 in the laparoscopic. Okay. 1.84 average per robotic patient and 4.46 per laparoscopic patient. Okay. 17 of these patients of mine didn't use a single narcotic. Now, they were on ibuprofen and Tylenol, but so were they. They were on the same non-narcotic regimen of ibuprofen and Tylenol. But for some reason, they used less. And I said, I'm onto something here. So, and I still think it's because of the precision of the surgery causes less pain for the patient, the actual precision that you're using compared to laparoscopic surgery. Okay. Now, where you'll see the biggest advantages, and I'm not a colorectal surgeon, but I do colorectal surgery, so my numbers aren't high. So if I was a colorectal surgeon giving this lecture, my numbers would be in the hundreds, even to 1,000 of colon cases. Well, I don't do colon surgery on a regular basis. I do it when it comes in, I'm on call or, so my numbers are low. But now, so what I'm showing you here, this is a hand-sewn intracorporeal anastomosis, okay? It's sped up 4 times, so I'm not sewing that fast. I'm not that great. But it is awesome to be able to sew intracorporeally, which means inside the abdomen, okay? So 31 cases I have on the books. The beauty of it is I don't need an assistant. So if I was doing this laparoscopically, my partners and I would always assist each other. Okay. So if you are sitting there for 3 hours as an assist surgeon, you only get to bill 20% of what the primary surgeon is charging. So you're sitting there for 3 hours watching your partner operate and you're making 1/5 the amount of money they are. Okay. Well, now guess what? I don't need a system. Leo has an arm for a camera and an arm for an instrument. And so since I've been doing robotic cholecystectomies, I don't need an assistant because I have what we'll call Leo. All right. Length of stay. So if I did a laparoscopic sigmoidectomy, I'd do it on Monday. They'd probably go home Thursday night or Friday morning at the earliest. Now they're going home Wednesday. Okay. I've reduced my length of stay in the hospital. Firefly. We use the Firefly where you're doing that fluorescent surgery. So before you take two pieces of bowel and you hook them back together, you're looking at the perfusion of it to make sure it has a good blood supply. Twice in my career, I have thought using white light and my eyes that I had sufficient blood supply to one end of the bowel. And when I went to Firefly, I realized I did not, and then I had to resect an additional piece. Okay, that's a huge advantage because if you hook two pieces of bowel back together and the blood supply is compromised on one side, you have an anastomotic leak. That patient's severely infected, is going to need require surgery. So that technology has saved me twice where I thought I had adequate perfusion of the end of the bowel and I did not, and I had to adjust my approach. And I thank the creator every day for giving me Firefly. All right, intracorporeal hand-sewn anastomosis. That's what I'm doing here. Okay. So why is this good? Because before, when I did it laparoscopically, I would make a big hole in the abdomen and I would bring the two pieces of intestine outside of the abdomen, staple it together, and then drop it back in. Okay. So that means I had to make a big hole. So you're losing the advantage of minimally invasive. And then you have to mobilize the bowel. And so you're putting stretch on the blood supply. And basically, with this, you do less dissection. That's better for the patient. And there's not tension when you're sewing it together because it's just laying there right next to each other. You're not exteriorizing it to the outside trying to do this anastomosis. And then you're able to sew, something that laparoscopic surgery has taken away from surgeons. You don't really do a lot of sewing in laparoscopic surgery. So you've lost that beautiful skill that you used to do when you did open surgery. So now we're doing beautiful hand sewn anastomoses inside the abdomen, which I think are better than staples. Okay. And these patients do so much better. Okay. So that is it. I'm going to let that play while so you don't have to worry about me ending. Okay. So we're going to do some question and answer while that's still playing. Okay. Pam? Okay. So when we look at our overall robotic gallbladders at Riverton, we have done 930 robotic cholecystectomies at Riverton. We have one infection. And that was because of a guy had a really bad gallbladder and he had peritonitis after we did the gallbladder. I took him back, I washed him out. There was no bile leak, there wasn't any damage to the bile ducts. It was just a bad gallbladder and he was infected. So 930 robotic cholecystectomies done at Riverton, which debunks that robotic cholecystectomy article because we have 0% conversion to open procedures. We have 0% blood transfusions. We have 0% bile duct injuries. Okay. No one has numbers like that. And we have debunked that silly, silly argument that we shouldn't use gallbladder on the robot. I think the robot was designed to do gallbladders because we have gotten so good at it.
Quick question and potentially follow-up. You mentioned that residency, or you mentioned in our training that this is how we put the money relevant to. Is that happening now in residency trainings and for general surgery or whatever it is?
Yeah. So if you go up to the U has two platforms in their room. So at the U, you can sit down and have a robot console, two robot consoles. I was training a transplant surgeon up there how to do some incisional hernia repairs, and it was really nice. So I just sat down at the monitor at the console when was able to instruct him with these little gadgets and show him, okay, put your stitch here, put your stitch here, and he was over there and I was there and I could see everything. And also in their training room. And the reason why I'm saying University of Utah because that's the only program in the state. And also in their offices, they have a console where they can practice modules. Okay, so you can train on this. You can put modules on there, and the surgeon resident can train when they're just chilling on call. They can actually practice on that on a module. And so, yeah, every training program will have a dual console. So general surgeon was late to the party. The gynecologists and the urologists were using robots way more than we were in the beginning. So if you're going to do a gynecology residency, you're going to be doing hysterectomies using a robot. If you're in a urology residency or fellowship, you're going to be doing nephrectomies and prostatectomies with a robot, and that's just their standard way of doing it. So you're going to see it in all those fields. And you know, if you go to a program that doesn't have a robot for these types of surgeries, I wouldn't go there. It's just a waste of time.